It is my distinct honor to welcome Dr. Anna Zisman, a renowned nephrologist and a distinguished leader in the kidney stone prevention and management, to our Madison Grand Rounds. Dr. Zisman is an associate professor of medicine in the section of nephrology at University of Chicago. She serves as the clinical director of the Kidney Stone Prevention Program, the largest program of its kind in the nation. In addition, she is the program director for the Nephrology Fellowship and the chair of the American Society of Nephrology's Kidney Week Kidney Stone Pre-Course. Her academic journey is equally impressive. She earned her medical degree from University of Wisconsin, followed by a residency in intermedicine at Northwestern University and a fellowship in nephrology at University of Chicago. Since then, she has made significant contributions to the field, holding multiple leadership positions that have advanced education, clinical care, and research in nephrology. Dr. Zisman's research investigates racial and genetic differences in the development of nephrolithiasis and chronic kidney disease. Using innovative endogenous lithium clearance techniques, she evaluates genetic variation in the proximal tubule function across race and gender. Her work has uncovered striking racial differences in nephron function, providing critical insights in the disparate occurrences of kidney stones and chronic kidney disease across ancestral backgrounds. Her groundbreaking research has been published in leading journals, and she has authored pivotal reviews, book chapters, and consensus statements that have shaped nephrology practice. Today, Dr. Zisman will share her insights on kidney stone prevention, opportunities for intervention in a systemic disease. Please join me in giving a warm welcome to Dr. Anna Zisman. Over to you, Dr. Zisman. Thank you for joining us today.
Thank you very much for that very kind introduction. I'm excited to be here. I am very passionate about sharing tips and tricks on kidney stone prevention, particularly as it relates to opportunities for long-term intervention. As I will hopefully convince you, it is a systemic disease that warrants our attention. So I have no disclosures relevant to this talk. So as I said, I hope that I can convince you today that kidney stones are more than a pain. We all know kidney stones are unpleasant if you've ever seen a patient with one or had one, as one of the 10% of the population or so that has suffered from kidney stones. But what I hope to show you is that it's also a harbinger. It's the proverbial canary in the coal mine. And I think that paying attention to it from that lens may give us the opportunity to provide better care to our patients. So kidney stone formation, a large proportion of the population has risk factors. So if you've had a kidney stone, you're more likely to develop one in the future. We know that our population is getting more obese, struggling with diabetes, gout, high burden of hypertension, all of which are associated with kidney stone formation. Our diet as a nation is less than optimal, so there are dietary risk factors with high salt, high intakes of processed food. And then there's a subgroup of patients who have enhanced enteric oxalate absorption, whether after bariatric surgery or as part of GI disease, IBD, and so on. But perhaps even more striking is that the clinical associations going forward. Once you have a kidney stone, you are more likely to suffer from or be diagnosed with hypertension down the line, with coronary artery disease, CKD, and ESRD, and bone fractures and osteoporosis. This is not to say that this is causative. These are associations, but the associations give us an opportunity to identify patients who perhaps warrant closer attention. Just to give you some examples as far as the association with hypertension, this is data out of Olmsted County, so the area surrounding Mayo. Looking at their population of stone formers, once you were diagnosed with a kidney stone, the incidence of a hypertension diagnosis at 15 years was about 25% in stone formers compared to about 10 to 15% in controls. And remember, oftentimes it's a young patient population that is identified with kidney stones, so in your 20s or 30s. So this is a time to identify risk factors that can be addressed going forward. How about MI? You see a very similar line. This is controls. This is stone formers at 18 years. Incidence of MI was about double, so about 4% versus, or maybe less than double, but much higher in stone formers versus controls. Vascular calcification. Young kidney stone formers have a much higher prevalence of subclinical atherosclerosis when people have looked at carotid intima and media wall thickness. There is much higher carotid radial and carotid femoral pulse wave velocities in stone formers, which correlates directly to lower bone mineral density scores. And kidney stone formers have much higher aortic calcification scores relative to age and sex matched controls. And again, remember, this is not your 80-year-olds. This is young people. Association with bone health. There was a study out of the VA that showed that 1 in 4 patients diagnosed with kidney stones, and this was because it's a VA population, an older population and largely male, had a history of fracture or osteoporosis. If people didn't have a prior diagnosis of osteoporosis or fracture, once diagnosed, in the following 5 years, 12% had a diagnosis of osteoporosis or suffered a fracture. Only 10% underwent DEXA screening, which is abysmally low if you think about it. And 20% of those were diagnosed with osteoporosis. Interestingly, DEXAs were much more likely to be ordered if they were seen by urology, endocrinology, or nephrology, which is one of the reasons I'm here sort of preaching this as, once you identify a patient with stones, think about their bone health from an internal medicine perspective. Again, this is your opportunity to keep that canary alive. Again, this is another study looking, this was a meta-analysis of all relevant studies to that point. This was in 2016 of kidney stones and osteoporosis. And you can see that in every single study, there was an increased risk of osteoporosis in anybody who was a kidney stone former. Going back to Olmsted County, this is risk of a fracture in men and women following the initial episode of stone disease. And you can see that at 30 years, and again, if you start young, you've got a long time to follow these people. Men had an incidence of about 25%, women almost 40%. So you are almost, close to 50-50 on having a fracture down the line once you've been identified to be a stone former if you're a female. NHANES, looking more prospectively in people who had a stone diagnosis, men were found to have a much higher incidence of fracture. Women actually did not reach statistical significance. That said, obviously a lot more competing factors for women for causes of fracture. And this is from the same study, looking at risk factors between men and women for a decrease in BMD, and history of kidney stone was significant in men, as I mentioned, not so in women, but BMI and milk consumption were notably significant. Now, this is important because if you look a little closer, milk consumption, and so basically as having high urine calcium as a risk factor for stone formation, you can see patients with no kidney stone history and kidney stone history, those that didn't take sufficient milk in or dietary calcium had a much higher risk of a low bone mineral density compared to those who didn't have a kidney stone history. So basically, even if it didn't reach significance for a fracture, bone mineral density was lower in stone formers who did not eat sufficient dietary calcium. So taking a step back, I've hopefully convinced you that it's something worth paying attention to. But who are we paying attention to? Well, it's actually a lot of people are at risk for stones. In the US, the most recent published data say 1 in 11 people. This is from NHANES 2007 to 2010. And there are abstracts saying that more recently it's closer to 11 to 12%. The prevalence continues to rise in the US. In the NHANES data set from the 80s and 90s, the prevalence was 5.2%. And this has been associated with a marked increase in ER visits. You can see over the course of 12 years, there was almost a doubling in ER visits due to stones. What kind of stones do people make? This is data from Mayo, which serve as a national reference lab. So people will send stones from all over the country. We send our stones to them here from U of C, and they looked at almost or over 46,000 stones from 43,000 people. And looking at men here on the top and women on the bottom, the most common stone type is calcium oxalate. So calcium stones are the most common in both men and women. You can see in women, there's this white squares come into play more significantly. This is calcium phosphate or apatite stones. Historically, it's been thought that it's because women have more frequent urinary tract infections, leading to higher urine pH. Research from our group and others suggests that may not be the case. It may be more related to GI absorption of alkali. But point being, the most common is still calcium of both types, calcium oxalate and calcium phosphate in both men and women. As people get older, you start seeing more uric acid stones. You can see this line heading up both in men and in women. And then brushite, which is another type of calcium phosphate stone, is much more rare, but much more problematic. So how does one form a kidney stone? What are the causes? Well, historically, we've often said, it's idiopathic. We don't know why they form, but we're starting to recognize that they're probably a huge genetic component, and it's the interaction of genetics and environment. So to be called, general stone disease or idiopathic stone disease, there's no systemic disease noted, or as I point out, they're overtly noted, because realistically, kidney stone disease is a systemic disease. Usually there's an underlying metabolic derangement that you can identify. And I'll go through that in a little bit. And then there's always lifestyle factors that may be coming into play, whether through diet or types of jobs. If you're a truck driver, you may not be wanting to take in a lot of fluids and have to stop to use the restroom. I struggle with a lot of kindergarten teachers, ophthalmologists who don't like to leave the OR. Those are just some examples of lifestyle factors that could contribute. Here we have a large, in Northwest Indiana, which is right next to us, we have steel mills, and the hot environment there certainly comes into play as well. Monogenic diseases are much more rare, but more recent estimates suggest that there's about 15% of patients coming into a general stone clinic actually could be identified as having a genetic component with an identified gene. As I'll show you, the most common thing is hypercalciuria, which is not monogenetic, but genetics are, again, likely playing a part in a large component or a large proportion of disease. You can see some of the monogenic diseases listed there, and then you always have to rule out acquired disease, so primary hyperparathyroidism causing hypercalcemia and hypercalciuria. Bowel diseases, as I mentioned, IBD, patients with ileostomies have large losses of fluid and alkali from the gut. And so essentially, you have to take a very thorough history to identify potential risk factors. So let's focus on calcium stones to start with. How does one make a stone? Or in other words, how do you become supersaturated? Because that's the first step. So hypercalciuria, as I mentioned, idiopathic or genetic, is prevalent in about between a third to 2/3 of patients. Hyperparathyroidism is much more rare, and then genetic and systemic disease leading, sarcoid, lymphomas can give you 125 excess and 125D excess and cause hypercalciuria. Hypocitraturia is present in about a third of patients, a fifth to a third of patients as a primary disorder. Some estimates suggest that this may be higher, closer to 50% as a secondary disorder. Hyperoxaluria can be dietary, so everybody has read that nuts are good for you. You go to Costco and you get a bag of almonds, and I have seen this happen, and your urine oxalate goes through the roof. Enteric would be after bariatric surgery or through IBD, and then primary hyperoxaluria is a genetic, a much less common and a rare genetic disorder. Hyperuricosurious, so too much uric acid in the urine, is present in about up to a third of patients. And this is not a risk factor for uric acid stone disease. It's a risk factor for calcium stone disease, as it predisposes to crystallization as a nidus for stone formation. So going back to this idiopathic hypercalciuria, high urine calcium without a systemic reason that you can identify, you need to have a normal serum calcium to make that diagnosis. This is present in about 50% of calcium stone formers. It's a monogenic, it's a polygenic trait. It's not monogenetic. And it's passed down in an autosomal dominant type picture. But again, this is not a single gene. It's appears to be a polygenic trait. So as I said, familial, if you have hypercalciuria, each of your children has a 50-50 shot of being hypercalciuric. But that does not mean that they're going to form a stone. It means that diet and lifestyle influences may play a part as to whether they develop a stone event. And as I mentioned, hypercalciuria, idiopathic or genetic hypercalciuria, is a systemic disorder. We know it involves bone in terms of bone breakdown. We know it's actually more of a dynamic bone picture for if there's endocrinologists in the room. We know it's an intestinal disorder in terms of higher absorption of 125D, of 25D, and increased activity of 125D. We know that it is associated with bowel disease, period. And then, of course, the kidney and how the kidney handles calcium. My mentor, Fred Coe, published the seminal paper on this in 1979, identifying this as and sort of autosomal dominant trait. I love this story. He basically did this by he asked people to collect 24-hour urines and did fasting blood draws. And as a reward on Saturday mornings, he brought these families bagels and cream cheese to to celebrate being done with a 24-hour urine collection. And that is how you get a New England Journal article published in 1979. You can see these were 9 families, and there was a 50% penetrance of the trait. We also know that siblings of children who have kidney stones have higher urine calciums, even if they haven't yet formed a kidney stone. This is their calcium excretion on 24-hour urine. So this is normal kids. This is a sibling of a patient, of a child who has kidney stones. So they tend to have higher calciums. And then if they have themselves formed 1 to 2 stones or greater than 2 stones, you can see the calcium excretion continues to rise. So the degree of hypercalciuria is a risk factor for stone formation. Just looking at some twin studies showing support for the hereditary disease. This was data from the VA, looking at proband concordance between monozygotic and dizygotic twins. For probands who were monozygotic, a third of them had also had stones. For dizygotic twins, it was only 17%, which tells you, even for monozygotic people who have the exact same, DNA to start with, the effective environment is key. And then in another study, 12 monozygotic twin pairs, the urinary calcium, not stone formation, but the actual urinary calcium heritability was 94%, which again makes sense. Additional risk factors, location. So this was a projected risk in stone disease. This was published in 2008. This is the current stone belt in yellow. Virginia is here on the, you've got all 3 colors for predicted stone belt for 2050. And then for 2095, as temperatures get warmer. However, when you adjust for population, this looks even more striking for me here. This is new lifetime cases projected in 2050. So it looks like my job here is safe with projected 50 to 100,000 lifetime cases in Chicago land. So who do you evaluate and treat? So you have a patient who comes in and tells you they have a history of kidney stones. Who should be tested further? Well, the general recommendation is anybody who's a recurrent stone former, so more than 1 stone event. Anybody with a stone in a solitary kidney, those with a family history, somebody who develops kidney stones in pregnancy, people with bowel disease, and then factors that increase risk of recurrence. I mentioned that brushite stones are much more problematic. They're much higher risk of recurrence. And uric acid stones, much higher risk of recurrence, as well as actually fairly easy to treat, so definitely worth identifying. The AUA, the American Urologic Association guidelines say first-time stone formers don't need to be treated or evaluated for preventative measures. But then you look at the risk of recurrence based on the number of stones you've had. So for a first-time stone former at, let's call it 15 years here, you've got a 1 in 3 chance of having a stone recurrence. If you've had 3 or 4 stones, that number you can see here, much, much higher. So at 5 years, more than 50% likelihood of recurrence. I would make the argument, though, and my daughter in 7th grade just did a report on Animal Farm, and if you recall, all animals are equal, but some are more equal than others. I would argue that not all kidney stones are equal. So for a first time, let's say somebody tells you, yeah, I went to the ER and I had my first stone. And you pull up their images, and the person on the left is a first-time stone former. That says they formed they passed their first stone, versus the person on the right. They formed their first stone as well. I think it doesn't take a genius to figure out that the person on the left here is probably likely to have more stone events and is probably at a higher risk of a metabolic problem that should be identified. Versus, oftentimes this is, somebody got dehydrated, who knows, and, formed one stone. So I think it's important to not think about the guidelines as first-time stone formers versus not, but really evaluate the clinical picture. If you want to tell a patient what their risk of recurrence is, you can, there is a calculator, the ROX nomogram, for predicting a second symptomatic stone episode. Let me actually, I have to stop sharing, and then I will bring up the new share. So this is really easy to do. If this is their first symptomatic stone, yes. How old are they? Let's call them 40. Let's say they're male, white, family history of stones. If they had gross hematuria, let's say no. Let's say they had a run-of-the-mill calcium oxalate stone. Was there imaging? Yes. Was the stone at the UVJ? Let's say no. Was it a lower pulse stone? Sure. Is there another stone still present on imaging? Let's say no. And was there a prior incidental asymptomatic stone? Sure. No stone seen? No. All right, and let's see, how likely is our 40-year-old person who doesn't seem, had a run-of-the-mill stone, doesn't seem like their burden of disease was too bad on imaging. The nomogram says the risk of a second symptomatic kidney stone event at 2 years is 26%, at 5 years, 46%, and at 10 years, 66%. If it were me, I would like to know what I could do to prevent this, because I would imagine most people don't want a second stone event. So this is one way to talk with your patients about whether they would like to have further evaluation to identify any risk factors. Go back to my... All right. So let's say you decide you want to continue to evaluate. And how do you do that? Well, a thorough history. So is there bowel disease? Are they taking calcium supplements which are associated with stone formation? Have they been on meds like Topamax that are give you an RTA type picture? You get a family history, you get their dietary history, occupational history, etc. A stone analysis. What type of stone predicts risk of recurrence? As I mentioned, brushite stones, uric acid stones are much more likely to recur. You want to make sure you have a screening BMP on file, looking at kidney function, their potassium, their bicarb, looking for an RTA, and of course calcium to look for any systemic abnormalities of calcium. If you're a nephrologist and you have a microscope in the office, you could look at their urine for crystalluria. Some stone types have a pathognomonic presentation, for example, cystinuria. But the key is going to be a 24-hour urine. You want to do 2 to 3 24-hour urines, ideally on days that represent different time frames in people's weeks. So what do I mean by that? Ideally, one on a Sunday, return on a Monday, one during a work day. That one is a hard sell. Most people don't like to carry around a jug for a 24-hour urine collection. But what we're trying to capture is what do people look like on different days of the week with different sort of different risk factors for stone formation. So somebody who's a truck driver is probably not going to collect their 24-hour urine while they're driving. But their 24-hour urine when they're at home, I'm going to assume is going to look much, much better and is not representative of their day-to-day existence. What am I looking for in their 24-hour urine collection? I'm looking at how much volume they produce. So the higher volume is associated with less risk of stone formation. pH, calcium, citrates, sodium, oxalate, you can see the things listed there. And then supersaturation, which I'll go through in a little bit. Imaging, you definitely want to see, I showed you a difference between, a first-time stone former, identify the burden of disease. So I talked about supersaturation. What is that? So that's the key physical chemistry sort of event that needs to happen in order for the crystal to form and grow. So you need to supersaturate the urine with the stone material in question. And essentially, it means that the concentrations have exceeded that mineral's thermodynamic solubility. We know that levels of supersaturation in the urine of stone formers correlate with stone composition. And it's basically just calculated with a computer program, which takes into account volume, calcium, oxalate, phos, magnesium, citrate, pH, etc. Basically, any number greater than 1 means that you're supersaturated for that salt. Doesn't mean you're going to form a stone. Most of us are supersaturated for calcium oxalate, for example. Most of us are running around with values of about 6 for calcium oxalate. But we know that if you are a stone former, we want to decrease that number to decrease risk of recurrence. We know that treatment that lowers supersaturation is effective in preventing stone recurrence. And this allows us to emphasize the concentration of urinary constituents, not just their excretion rates. So 2 people can be hypercalciuric, both can have 300 milligrams of calcium in their urine, but if one has 1 liter of urine volume and another has 3, the person with 3 liters is going to have a lower supersaturation and therefore lower risk of stones. It's important to note that supersaturations vary over the course of the day. As you can imagine, they're highest at night when you're sleeping and not eating or drinking. But it also is important to remember that when we look at a 24-hour urine, and the values might look, just the borderline, they look safe, but remember that's an average of, when things look great, maybe earlier in the day versus potentially worse while somebody is sleeping. So looking at the components of supersaturation, volume, and stone risk, this was done by Fred Coe, my mentor, taking the data from the various health professions study for men and nurses' health study. These were longitudinal studies where they pulled out prospectively the associations of urine volume with the risk of stone formation going forward. So the nurses' health study is women, as I said, in red, and blue is males in the physician's health study. So you can see as you get a higher and higher volume, the relative risk goes further and further down. The lower your urine volume, the higher the stone risk. What about calcium excretion? You can see that there is a linear relationship. So as the definition of hypercalciuria is 250 for a woman, 300 for a man, but it is important to remember that's just a research definition. Ultimately, you can see the higher the value, the higher your relative risk of becoming a stone former. Oxalate, you need to get up into, starting at about 25, the relative risk starts to go up. both in men and women. The point here is that looking just at all of these are continuous variables. So looking at just the cutoff for normal is not useful. And then citrate is an inhibitor of calcium crystallization. And you can see the lower your urine citrate, the higher your risk, which starts to fall off somewhere in the 400 to 500 range here. So what do we do? Directed stone prevention means targeting lowering supersaturation by targeting the specific issues at play. So the individual urine parameters that contribute to supersaturation, and every person is going to be different. Now, their supersaturation may actually be fine. So you could say, oh, look, you're actually doing okay for stone risk, but hey, you're still hypercalciuric. And if you're hypercalciuric, that's a risk factor for, bone health and fracture, if not cardiovascular disease. So certainly want to make sure that you're addressing the individual as well as the whole. And we know that this works. This is data from our program. This is people with various degrees of compliance and returning to follow-up versus those that were highly compliant. The risk of relapse was way, way lower. And the treatment here was fluids, targeted dietary advice, and meds as needed. So let me show you a quick case. So this was one of my patients, 40-year-old female, had acute renal colic, had bilateral ureteroscopy with laser lithotripsy, and her stone analysis came back 100% calcium phosphate. She didn't have a family history of stones, but she did have a mother who was diagnosed with severe osteoporosis at age 65. And when I say metabolic evaluation, this is what a litholink urine, litholink is the lab we use. There are others, but if you're going to do this, you have to make sure that the lab that you're working with has the ability to do supersaturations. Now, this litholink color codes it, so it makes it very easy to identify risk factors. But let me take you through what generally we're looking at. Volume here is first, perhaps because it's the most important. You can see the normal reference ranges are not necessarily reference ranges for stone formers. But for anybody who's a stone former, we're target 2.5. Calcium here, you can see very high in red. Her oxalate, her citrate is normal. Supersaturation here for calcium oxalate and calcium phosphate. The calcium oxalate is reasonable. Calcium phosphate quite high because her pH is on the higher side. Salt intake. PCR is the protein catabolic rate. It tells me how much protein she's eating. And then we always start by looking at making sure that it's an adequate collection, so that their urine creatinine is expected based on their muscle mass. So as I mentioned, her calcium phosphate supersaturation is super high. Her volume is okay, but her calcium is what's driving the supersaturation, perhaps because of a high dietary protein intake. So if I wanted to decrease her supersaturation, what can I do? Can I ask her to increase fluid intake? Always. That's always going to be step one. In her case, it's not terrible, but there is a randomized controlled study showing, Borghi did this in Italy, randomized people to a target of 1 liter, or rather, target of 2.5 liters, and the controls ended up with a volume of about 1 liter. And you can see the percent forming a second stone at 5 years was decreased to about 10% from about 30%. This paper by Parks is from our program, from people who were not compliant. You can see the risk of recurrence of 5 years was 40%. So we know targeting a fluid intake of greater than, we target greater than 3 liters to have a urine volume of greater than 2.5 liters per day, and that's what the guidelines say. Now, certainly somebody who is a an athlete or has higher losses will require higher fluid intake. How about calcium? Can we lower calcium intake? If it's too high in the urine, maybe we should take less in. No, so that doesn't work. We know that lowering calcium intake actually increases stone risk. And the reason for that is that it will increase urine oxalate. Not only that, but it will worsen bone disease and risk of fracture. So this was a study looking at the percent of oxalate that is absorbed at every level of calcium intake. And you can see that the higher your calcium intake, the higher the lower the amount of oxalate absorbed. And if you have too much urine oxalate, you have risk of calcium oxalate stones. And this was a paper from Gary Curhan in Boston showing the same thing, looking at the Physician's Health Study. So mean calcium intake, if you got above a level of 0.5 gram, the higher you went, the lower your relative risk of stone formation. Now, you don't want to go crazy here because this will become a U-shape, as demonstrated by the Women's Health Initiative study. When they got up to about 2.5 grams, the risk of stones went up. There was a 17% incidence of stone disease in the Women's Health Initiative study. But they were eating about 1.5 grams plus supplementing with 1 gram of supplemental calcium. So Borhe, the same guy that did the fluid study, did a diet study comparing a low calcium diet versus a normal calcium diet, coupled with a low salt and low animal protein diet with the same amount of oxalate. You can see that the risk of recurrence was significantly lower on the normal calcium diet compared to the low calcium diet. Now, fractures. This is particularly important because if you try to, this is not in people on low calcium diets, but you can see that compared at every age, the risk of the risk of fracture is significantly higher for both men and women if they've had a history, which we already covered. But what this study showed us is that the median time from diagnosis to fracture was about 10 years. So you've got about 10 years to really impact and decrease the amount of hypercalciuria to prevent fracture in your patients. Stone disease is a disease of the young. Oftentimes people have their first stone in their teenage or early 20s. This is a meta-analysis of all the studies showing in kids with hypercalciuria their bone mineral density. And you can see the ages here, and you can see that the Z-score was almost universally lower compared to healthy controls. This is important because based on their work, they estimated that 10% increase in population peak bone mass decreases risk of fracture by 50%. So again, an opportunity to intervene early and identify people at risk. Okay, for decreasing supersaturation, I want to lower their urine calcium. What can I do? So we've already established that we want them to keep eating the calcium, but lowering salt intake, yes, because this is a compilation of all the studies in the literature showing the association of sodium intake and urine calcium. The higher, this is in both stone formers and normals, as well as in both prospective and retrospective studies. But what this is showing is the relationship as the higher your urine sodium, the higher your urine calcium. So limiting dietary sodium intake to less than 2,300 milligrams or 100 milliequivalents is going to help lower urine calcium. And Mediterranean and DASH diets have both been associated with a lower risk of stones, with their emphasis on sort of a balanced diet and low salt. How about thiazides? Well, up until recently, there were 3 major studies looking at the effect on supersaturation and stone recurrence. The three studies looked at hydrochlorothiazide, dosed BID, chlorthalidone, or indapamide, which is a thiazide-like diuretic. And you can see all three studies demonstrated a decreased risk of recurrence, dropping from 40 to 60% to 10 to 20% at 3 years. About almost 2 years ago now, there was a study in the New England Journal, and all the newspapers covered it, and I had all my patients calling me saying that hydrochlorothiazide does not work for prevention of stone recurrence. The study was the largest study done. The authors should be commended for that. But what they did is they used hydrochlorothiazide only once a day, and they used CT imaging at both the start and end of the 3 years. But they identified stone passage. So if you had a stone in the beginning, and then you passed that stone during the 3 years, and then you had no new stones formed, that counted as a failure of thiazide therapy. More recently, there was also a study done that showed that it requires about 5 years of therapy to show the long-term benefit of thiazides. So this is a summary of the studies that have been done, the eligibility criteria, and the intervention. And the study in the most recent New England Journal study did show actually a benefit, a radiographic benefit at the higher doses, even with once-a-day dosing. But there's been a lot of criticism by myself and others of this work in terms of not following it out long enough, not using long-acting thiazide, and using the CT, the definition of failure of therapy. So I would strongly advocate for continuing use of thiazide in the appropriate patient population. How about fracture, right? Thiazides decrease urine calcium. This is in all the this is a meta-analysis of all the studies done looking at thiazides and fracture. You can see initially the number of patients that were involved weren't tremendously high, but now more recently we're getting into many thousands of patients showing a significantly decreased risk of fracture with ongoing thiazide use. There is actually a thiazide receptor in the bone, so not only are you decreasing the urinary excretion of calcium, you're actually directing the thiazide, or you're directing the calcium to the right place in the bone. How about protein intake? I mentioned our patient may have been having excessive dietary protein intake. Clinicians, the guidelines say that clinicians should encourage patients with calcium stones and relatively low urinary citrate to increase their intake of fruits and vegetables and limit non-dairy animal protein, expert opinion. And then those with uric acid stones or calcium stones with high urinary uric acid to limit intake of non-dairy animal protein. Again, expert opinion. Interestingly, recent literature does not show increased risk of bone disease with acidic diet, which is the concern with the high protein diet, in the general population. The International Osteoporosis Foundation advises quote-unquote normal protein intake, which you can see listed there. So greater than 0.8 grams per kilogram per day. So that PCR number that I showed you, that's this value. The data is limited. I think that normal protein intake is very reasonable. I think we have definitely seen that very high intakes of protein do increase urinary calcium. So we've the majority of us in the community sort of advocate for moderation and having a normal, so 1 gram per kilogram per day is probably reasonable. Mediterranean diet, people don't eat just nutrients, people eat diets. And so when our patients ask us what they should eat, Mediterranean diet has been associated with a lower risk of stone, as well as adherence to a Mediterranean diet has been associated with a lower risk of low bone mineral density. Um, how about sugar sweetened beverages? Those are associated with lower bone mineral density and stone disease, so probably should be avoided for a variety of reasons. So back to our patient, we recommended maintaining increased fluid intake. We started indapamide, so a longer-acting thiazide-like diuretic, asked her to limit dietary sodium, and advised moderation of dietary protein intake, so 1 gram per kilogram per day. How did we do? Well, the volume, she did great. She increased that. The calcium dropped markedly. I will note she did not decrease her dietary sodium intake, so this was all thiazide. And you can see her risk, her supersaturation, has become negligible. This was also having decreased the protein catabolic rate, so how much protein she eats, to 1.2 grams per kilogram per day. So a success story. Things that our patient didn't have a problem with, but to sort of highlight, lowering urine oxalate. For people who have a high urine oxalate, there's debate about whether lower oxalate intake should be sought. Looking at the 3 cohorts that I talked about, the nurses' health study and the physicians' health study, only the highest quintile of oxalate intake was associated with stone recurrence, or excuse me, stone occurrence. And the reason that we are cautious is that a lot of the high oxalate foods are actually the things that are really good for you. And we talked about the cardiovascular disease burden. Probably don't want to limit those, the healthy fruits and vegetables. So generally, we would target increased calcium instead, unless, again, the person with the Costco bag of almonds notwithstanding. Citrate. About a third of stone formers have hypocitraturia. We talked about how citrate complexes calcium and inhibits crystallization. And the etiologies of hypocitraturia can vary from idiopathic, which in other words is genetic. Systemic acidosis will give you hypocitraturia, for example, an RTA. And then hypokalemia. So we have to be cautious when we start our patients on thiazides to make sure that we don't induce hypokalemia, or if we do, to replete. So for increasing urine citrates, we want to advise diet rich in fruits and vegetables, sure. Potentially potassium citrate, sure. Skip over this. Basically, this is identifying all the studies that have shown that alkali neutralize the bone effects of a Western diet, so lots of fruits and vegetables are good for you, and that's both in normals and in stone formers. And there have been 2 large controlled studies of citrate in recurrent calcium stone formers, and you can see the risk of relapse goes down significantly. Just to quickly, and we're running out of time, but quickly shift gears, this has all been focused on patients with calcium stone disease. For uric acid stone disease, that forms at a low urine pH. And so potassium citrate could be useful to alkalinize the urine to decrease risk of uric acid stone recurrence. And the reason that pH is super important and identifies people at risk for problems down the line, it's actually one of the earliest things that you see in metabolic syndrome is a drop in urine pH. And when you look at uric acid stone formers versus controls, it's not how much uric acid they're excreting, because you can see that is the same. It's the difference in pH. So controls have significantly have a normal urine pH of around 6, whereas uric acid stone formers are closer to 5.3 or so. The pK of uric acid is 5.3. And again, this is identifying people at risk for metabolic syndrome because as body weight goes up, urine pH goes down. This is due to insulin sensitivity. For any endocrinologists in the room, as the glucose disposal rate goes up, urinary pH goes up, or more importantly, as it goes down, the urinary pH goes down. Quickly, treatment of uric acid stones. You want to identify why. So low volume, whether from GI disease or lifestyle, low urine pH, GI disease or metabolic disorders. And hyperuricasuria is highly unusual as a cause of uric acid stone disease, unless you're talking about myeloproliferative disorders. Increase urine volume, alkalinized urine, and very rarely allopurinol. I'm going to skip this. So again, the goal is to lower supersaturation, lower stone risk, and address individual risk factors for systemic complications. You want to address potentially modifiable risk factors such as obesity, diet, and then use the 24-hour urine collection to direct individualized management, but also to motivate the patient who can see changes in their lifestyle leading to changes in their numbers. For all stone formers, increase urine volume. For calcium stone formers, try to lower urine calcium with low sodium and potentially thiazide, normal calcium diet, and then fruits and vegetables. For uric acid stone formers, increase urine pH. And again, take the opportunity to intervene. A stone former in their 20s is a bone fracture waiting to happen and potential risk of cardiovascular disease down the line. Don't allow the bird to do that. And with that, I apologize. I ran a little over, and I thank you, and I'm open to any questions.
Thank you so much, Dr. Zisman. It was a wonderful presentation. With this, we will, go to the Q&A session. Dr. Flemmer.
And secondly, is there not a risk-benefit ratio between using thiazides, which are bad for the heart, but good for hypercalciuria?
So I didn't hear the first part of the question. I will answer the second. As with anything, there's always risk and benefit. I would say that the studies would suggest, all HAT and all, would suggest that thiazides can be quite good for the heart when controlling hypertension. But yes, risk benefit in everything.
The second question is, how does fructose cause stones, high fructose intake? Is it just by pH or calcium?
We don't know for sure. There's been a lot of work. Dr. Johnson out of Colorado has been very focused on this. It seems that it's more pH and insulin resistance driven.
Thank you. With this one last question, Dr. King.
Thank you. I'll try to make it quick. That was a great talk. Thank you very much. Should we be getting bone densities on everyone with their first stone, regardless of age and gender?
This is not a guideline-driven answer. This is a sort of in the falling into the expert opinion realm. I would say if they're hypercalciuric, yes. If they are, and you sometimes have to fight the insurance companies to do this, but I've been able to do that. If they're not hypercalciuric, there's no reason to believe that they have any issues with their bone mineral density. But if they are hypercalciuric, particularly with a family history of same, I would absolutely do.
Thank you.
Thank you so much, Dr. Zisman.